Look, James, there's this Dr. Jake Fantus who's published articles on guideline discordant care in testosterone replacement therapy in the era of telemedicine, and even a secret shopper study when they go into these telemedicine clinics and see how many peptides they're prescribed with a normal testosterone.
Yeah, we discussed the secret shopper study, and it's just fascinating how someone goes in with one problem and they're offered 7 solutions for problems they didn't necessarily present with. So wouldn't it be cool if we could get the author of that study to come on our podcast?
I would be the biggest fanboy. Welcome back to the Gillett Health podcast, where we give you tools to develop a balanced approach for health. I'm Dr. Kyle Gillett.
And I'm James O'Hara, nurse practitioner. Today we are joined by Dr. Jake Fantus. I'll let you tell the listeners a bit about yourself, what you do, where you went to school, and why you're so awesome.
Well, I don't know about that last part, but thanks for the introduction. I'm Jake Fantus. I'm one of the urologists at Kansas University, not too far away from here. I did my medical school at Baylor College of Medicine, and I did a urology residency at the University of Chicago and a fellowship in men's health, which encompasses male sexual health, reproductive health, infertility, and male hormone replacement. And it's nice to be on the podcast. Thanks for having me, guys.
Absolutely. Interesting story about how we first heard about you and then how we met you, which is actually completely different. But as many people know, we are fans of a lot of the clinical literature that you have published in the past. Probably well more than a year ago, we discussed a study called a secret shopper study, and where a sort of hypothetical patient goes to several telemedicine clinics and then sees what happens. But basically, we were fans and we thought, man, it would be so nice to talk to one of these authors.
Yeah, basically a patient with normal or even pretty good testosterone levels is going to these different TRT telemed clinics and seeing what they have to say, what they check for, more importantly, what they don't check for. And I think you came into the clinic for a lunch and we were like, oh yeah, we did a podcast on this study. And you're like, oh, I published that study. So I was like, wow, that is very cool. Small world.
Yeah, I mean, one of the biggest reasons we looked at this study to begin with is pre-COVID, there's such a huge uptick, as you guys know, in the number of people using these direct-to-consumer sites for things like Viagra and Cialis. And then we started to see this slow transition into people starting to use more and more testosterone. COVID happened, telehealth really took off, and there was a major concern that, there are drugs that are more dangerous than Viagra, things like testosterone that have potential side effects and that may not have been prescribed in a safe manner. So when I was at Northwestern, some of the other faculty and one of my colleagues who was coming in the year after me decided to put on this secret shopper study where he had a grossly normal testosterone. I think it was 650 if I'm remembering correctly. And then we pulled all these different things saying, hey, I have low energy, I have low sex drive, I think I need testosterone. And it was amazing the number of responses that we got. There were several people that basically said, well, that lab wasn't done when we said it could be done, and we discarded them. I think we ended up with 7 total companies. And I know you guys have reviewed this before, but actually being able to hear the script, hearing the actual people on the other end of the companies offering testosterone without asking appropriate questions. We could talk about the guidelines and things all you want, but the real problem we had here was the lack of questions about cardiovascular health, the lack of questions about whether or not somebody wanted to have a child in the future, not offering preservation, and then offering a lot of drugs that may be considered off-label. I mean, really, of all the 7 people we looked at, only one single study talked about fertility preservation, on one single center rather, which is just remarkable what's kind of out there.
Yeah, we thought the same thing, and maybe we can link to our previous videos that have discussed this. But one of the things that we found particularly interesting is a flowchart that you and the other authors had proposed regarding a future template for what telemedicine, hormone optimization, or HRT could look like or should look like in the future.
Yeah, I mean, I think things are evolving beyond that even right now. I mean, again, if you look when the guidelines were published, we're talking, it seems like just yesterday, but these things were 2018, 2012, and then 2023, depending on Endocrine Society, American Urological Association, and then the European equivalents of those. I think that the most important questions are the ones that we already somewhat addressed, is somebody's overall health, which is something you guys deal with all of the time. But when somebody comes in for a hormone evaluation to a urologist, a lot of times I'm getting, minimal amounts of wellness labs. And I talk to them about their fertility, but there's so many other reversible medical issues that can be addressed ahead of time. And that's kind of, again, the tip of the spear, so to speak, with that is doing a true male wellness exam, which I do think we have good infrastructure to do through telehealth. Beyond that, obviously, the labs. I think there's some digression in terms of how imaging may be involved, and without getting into too many things, but testicular ultrasounds and things that don't allow you to necessarily lay hands on a patient. But we have some ways to navigate that, with the hope that we'll be able to broaden access to these services, especially in areas that don't have knowledgeable providers.
Yeah, so expanding in a safe manner with good screening and monitoring in place for those that are started on testosterone in this manner. It's not, here's your script, see you in 12 months, and there you go. Because I think that is the case with a lot of these telemedicine TRT. It's kind of a high volume, low time with the patient sort of operation.
Yeah, and again, most of the stuff is strictly following the guidelines, which I would hope telehealth or in-person providers would have some understanding of how frequently to reassess labs after starting somebody on it, to make sure that their levels are where they're supposed to be, make sure they're not developing high levels of red blood cell counts that could cause things like heart attack or stroke. And also, again, near and dear to my heart for men over the age of 40 is making sure that they're not developing or had undiagnosed prostate cancer.
Yep.
So again, being very careful both with the initial workup and maintenance is incredibly important.
Yeah. Now, you have the opportunity where men who have perhaps gotten this testosterone and then their clinic went under, so they're coming to see you. Maybe they weren't appropriately prescribed or counseled at baseline. They're running too hot, and
TRT
they say,
plus.
I feel great. What's the problem? Why can't you just script me 300 mgs a week?
Sports TRT.
And if I may quote you here, when we had our initial conversation, I think you said something to the effect of, cocaine can make somebody feel great too, but it doesn't mean it's risk-free.
Yeah, I mean, that's absolutely true. I think where things get challenging is that I'm a physician. My job is to take somebody from a pathologic state and put them into a normal state. When we start talking about potentially super physiologic states, biohacking, things where we're trying to, go beyond what we would perceive as normal, there's nothing necessarily wrong with that. However, there's such limited safety data. So when we talk about the potential CNS or mind's effects of perception of testosterone is a controlled substance. It is an addictive substance when it's used past normal physiologic levels. Data is not great in this space, typically from anabolic steroid abusers. But the point is that too much of something can cause, permanent, long-lasting effects. And I do see these patients who've been on way more than 300. They're on other anabolic agents. And when you take them off, they feel terrible. And then a lot of them never come back. So that initial conversation of saying, hey, let's manage expectations here. I can't put you on 300 plus your DECA plus something else. And let's go down a little bit. Let's check your levels. Let's see what your blood count is. Let's get a PSA because you've never had one. I mean, setting realistic expectations, admitting where we don't know there's data, talking about the data we do know in a lot of these men where there's premature heart failure due to asymmetric wall thickening in men that have very high levels of different substances is important. But I think admitting ignorance, saying we don't know the safety, it's a limiter in my practice. I won't give somebody a medication if I don't know that it's safe. And I tell them that. And I've had a lot higher retention rates with a lot of these patients admitting that than trying to mimic something that they were previously on.
Speaking of safe medications, a lot of people have discussed how writing clinical literature can certainly help improve trends, and learning about new medications like auto-injector subcutaneous TRT or oral lymphatically absorbed TRT or nasal TRT. But lately, frankly, it seems like podcasts, much bigger than this podcast, have been largely responsible for popularizing subcutaneous TRT. Our good friends Andrew Huberman, Derek with More Plates, More Dates, they both talk about, just take your 0.2 subcutaneous 3 times a week or every other day, and it's perfect and you're good to go. And it's shocking to see the amount of people and patients that we see on regimens, regardless of what they're prescribed. They're doing this with insulin syringes. But at the same time, we send a prescription of subcutaneous TRT to a local pharmacy, and we get a call back from the pharmacist that subcutaneous is not safe because it's not sterile.
Or specifically, I'll say this. This is a message that a verbatim pharmacy gave to our nursing staff. You can't do that subcutaneously because it will cause an infection, which implies that there's zero risk of infection if you just do it intramuscularly.
Or intravascularly, as you know, that people do hit major vessels when they do it intramuscularly. My question to both of you, though, is have you seen people with differences in skin reactions from sub-Q and IM injections, to kind of put this back on you? Because I haven't noticed a difference. Some people have injection site reactions for both things if it's not done cleanly. But
as far as a reaction, I would say no. A bit more lumping. I think would be the case.
Mm-hmm.
Yeah.
There's also a difference between how deeply subcutaneous they do an injection, and we have certainly noticed a difference depending on the viscosity of a carrier oil with something like Nebido or Avede, which is just the European and US versions of testosterone undecanoate. I believe in castor oil. It's so thickly viscous, I don't think you would want to inject that subcutaneously. Maybe I could be wrong. But with the thicker viscosity carrier oils like cottonseed oil, perhaps a touch more lumping. But in most of those cases, those patients are coming in and they've been on too high of a dose, because the larger volume of the thicker carrier oil is going to be more likely to cause that in our experience.
Yeah, I'd completely agree with both of you with that. It's frustrating. The sterility of this is also because the people are drawing up more frequently, and these are supposed to be single-use vials. I get that a lot from the pharmacy saying that, okay, I give somebody 200, 1 milliliter, and now they're doing 30 every other day, 40 every other day. They're having to drop fractions and fractions of a vial. The sterility there may be a little bit more challenging than doing a depot of the entire syringe at one time. But I do think if we're talking about trying to most clearly mimic our physiology with these diurnal variations or something more closely, it makes way more sense to do something more frequently at lower doses than have these huge spikes. And as we know, the literature really supports that with a lot of the side effects, the increased red blood cell count and the like.
Yeah. I suppose one other benefit of a regimen of a lower or appropriately dosed subcutaneous TRT is that males are more likely to remain fertile. One thing that I've heard, which may or may not be true, is it usually a lot of males are, of course, have zero sperm counts or azospermatic on TRT. Maybe half of them if they were on appropriate regimen, probably a lot less if it's Natesto or maybe oral lymphatic testosterone. So I don't know what your estimate on that is. And then I guess the second part of the question would be, when someone comes to you and they're on TRT, they want to have kids, they want to start a family, do you always take them off, or do you tell them they're infertile forever since they've tried TRT?
All right. This is a good multi-part question. I think the first one absolutely range shoes with what you said. The published data in this space, looking at, part of the phase 3 trial for Natesto, specifically looking at the nasal gels and people having maintained spermatogenesis, makes a lot of sense. I don't have great data in the orals to present, but it's very likely to reign true just because you're not getting these high peak levels. And again, these high peak levels, we think, tell the brain to stop producing hormones, then tell the testicles to stop functioning. So you stop getting this testicular production, which is why all these people using these different regimens, which I'm sure you guys have discussed in other podcasts, makes a lot of sense in that space. As for people on TRT or other forms of replacement or even anabolic agents, again, I think the most important thing is having a realistic discussion. If you metaphorically pull the rug out from under them, take away all their testosterone, all their androgens, the chances of them coming back to you are pretty low. I know for a fact there will be some literature coming out and different replacement protocols coming out from Baylor in the next several months, looking at keeping people on TRT and then adding HCG and FSH, which are two hormones that will help restart the testicle in this space, so people actually aren't coming completely off. The historic literature would suggest that we should take them completely off and then put them on these other replacements, the enclomiphene, the Clomids, or the HCG, so allow them to restart naturally. But what we're seeing is that recovery of spermatogenesis likely can come without completely taking somebody off. As you guys well know, it's just the intratesticular testosterone that seems to be most important here, not necessarily taking away all the exogenous T.
And what would you say in terms of the timeline? So maybe someone went on testosterone 3 months ago and now their partner decides that, hey, it's time to have a kid, or someone who's been on testosterone for 10 or 15 years. Would your management be different for those patients?
Yeah, I mean, this is getting more into that. One of the papers I was going to quote, which is a paper of Lipschultz's, who is one of the modern fathers of male factor infertility, and really does show increased dose, duration are probably decrease the chance of a quick recovery of spermatogenesis. It also means the likelihood of them feeling anything in a short amount of time while they're completely taken off testosterone is low. So I'd be more inclined to keep somebody who'd been on testosterone for longer periods of time on testosterone, adding things like HCG and FSH. Typically, I won't recheck a semen analysis for at least 3 months. The life cycle of the sperm, depending on the paper you read, is somewhere between 72 and 74 days. And ideally, we would optimize that hormonal milieu in the testicle for that amount of time before we recheck to see whether or not they're fertile, and then adjust doses based on their response to the new dose, as well as their other levels, again, the FSH and LH levels that they're producing.
And is there realistically a concern about testicular fibrosis with long-term use? I've seen that talked about a lot, but not a lot of literature in the space.
The only literature, again, same paper, looks to be a little bit less than 2%. So I think it's pretty darn rare. The one thing we don't talk about that we don't have good data on is somebody comes in, let's say their sperm count, their total motile, the amount of moving sperm in their ejaculate is 500 million. So they're well within the normal range. They start testosterone therapy for several years. They come off, they're rebooted, so to speak. Now their total motile count's 150 million. Still well within the normal range, but as you can see, there's been a significant decrease, which we hypothesize probably wouldn't have happened. That's probably more important for people that are borderline subfertile to begin with. So people with lower counts, I can't tell you, but my presumption is that people with subfertility that get started on long-term TRT are more likely to be those people that really struggle with that testicular fibrosis because whatever remaining tissue they had was more affected.
Do you think this could also be an effect in people who took pro-hormones from GNC or a SARM cycle, the research chemicals, or even a steroid cycle for a shorter period of time?
Yeah, again, it's possible. A lot of it we do think, though, is basically shutting off that hypothalamic pituitary gonadal axis. I can't speak to necessarily the paracrine effects or the local effects of these different hormones within the testicle. The most of the data we have just talks about the inability for the sperm to be created due to levels of LH and FSH, those hormones being close to the sperm-producing cells.
Mm-hmm. Earlier, you mentioned intratesticular testosterone and how it's important for fertility. For someone who's interested in fertility and wants to understand that from a layman's perspective, is there a good way to explain that and then explain how SHBG might be related to that?
Sure. So testosterone is produced primarily in the testicles. There are some other androgens that are produced in the adrenal glands, which are the small glands next to the kidney. But the vast majority of our androgenic hormones or testosterone is produced in the testicles. And you can imagine when the body produces these hormones that there are different levels in different parts of the body. You mentioned SHBG, or sex hormone binding globulin, is a hormone that's designed to, or a protein that's designed to bind to testosterone and keep it in certain areas. There's so much of this SHBG in your testicle, in your bloodstream, and in other parts of your body designed to concentrate testosterone. So when your testicle is producing testosterone, naturally, there's so much of it that is sequestered or held within the testicle due to proteins, SHBG, and other proteins that allow it to stay there. So the concentrations, again, depending on the study, range from 50 to 70 times higher than what's in your bloodstream. So theoretical example, you have somebody with a testosterone of 500. That means they have 25,000 testosterone level of 25,000 nanograms per deciliter in their testicle. We put them on intramuscular or subcu testosterone. Now their levels are 1,000 in their bloodstream. The problem is that those high levels go back to your brain, shut this axis off, and now their testicles are seeing a testosterone of 1,000, which is 25-fold less than what they were previously seeing. And those concentrations are incredibly important for sperm production. That's how taking exogenous testosterone can shut down sperm production. A question I've gotten that has come out recently is there are examples of people that are bodybuilders or people on a lot of testosterone therapy that have pregnancies. And that's absolutely a phenomenon. You can imagine if somebody was on so much testosterone that they could actually upset that balance and have almost normal intratesticular levels of testosterone because they're taking so much exogenously, or they're doing something, intelligent and taking additional hormones that maintain that the testicular production of testosterone while being on testosterone therapy.
Yeah, it's something really interesting to contemplate. If you have a serum testosterone level pull from your arm of 25,000, then presumably have the same level in the testicular tissue, but you're talking about someone with that 500 natural. If you actually sampled it from, something venous near the testes, you would see that much higher concentration. I assume that's how those are done, but I may be mistaken.
So for intratesticular testosterone, we've talked about other markers like 17-OHP. Really, those markers are actually taken directly from the testicle, which is not something I'd recommend getting your testicle biopsy to get a intratesticular testosterone level. A lot of times we were doing these for part of cases, again, in subfertile men who get sperm extraction procedures or something along those lines.
Your example that you brought up, a total testosterone of 500, I think mine was 400, maybe 300s when I wasn't on finasteride. But before finasteride, before HCG, et cetera, I've mentioned, including on the podcast and my initial health podcast, that I have varicocele and heat damage. And before I took anything, I had atrophy of both testes. Both were smaller than the normal reference range, just from the heat damage over time. And then I took HCG and rectified that issue. But I did conceive 2 healthy male children before that, and I had very high SHBG. So, I know that varicocele is a very common question, and people have commented many times to talk more about this, less about prostates, more about varicoceles. But what should someone that might have varicocele or other concerns for testicular atrophy, a lost testy, et cetera, is there things that they should strive for, like high SHBG or naturally optimizing testosterone? Because I've always thought that SHBG is bad because it blocks your free T and you can't build muscle and you just want higher free T. But when you're talking about SHBG and fertility, it sounds like more is a good thing.
Yeah, I think that like anything else in the body, homeostasis or this working from some very small equilibrium fixed point is important. So too much of something is probably a bad thing, but not enough of it is probably a bad thing as well. So these are definitely competing interests by keeping the testosterone where you want it, but also wanting enough free or bioavailable testosterone to go into other places, such as, your biceps or your chest. Just a brief aside about varicoceles. If you want those fixed, I can fix those for you. I do get a lot of questions about varicoceles. There was a paper out of Cornell, I want to say it was in 2016 or 2017, showing increases in testosterone by about 100 points.
100. Yep.
Yeah, for this is a paper of Dr. Schlegel's group. Knowing the authors, it's ironic that a lot of them do not correct varicoceles in this space for low testosterone, which again, I think that we would need a prospective, a trial that actually was designed to show this difference. People may argue that difference is not very much, 100 points between people that already are grossly in the normal range. I'd given you that example of a sperm count from 500 to 150 million. When we start thinking about these things, we ask the question, something could be statistically significant, but is it clinically significant? These people with the 100-point increase in testosterone, do they feel different? Do they have more libido? Do they have more energy? Is something improved in their life? And if the answer to that's yes, then maybe we really should be considered correcting these varicoceles. But until we have that, until we have some kind of, data showing that there are health benefits beyond this small increase, that again was in a retrospective study, I don't think it's prime time to fix varicoceles. And I think manipulation and other things that are less invasive than a surgery make a lot of sense.
So is there a secret word or a secret question people can ask to get their varicocele fixed if they want to boost their testosterone? Do they need to say, hey, I've got some pain with this doc, for people that don't have the luxury of sitting down and having a nuanced conversation with you?
Yeah, so my speech is usually there are 3 reasons I correct varicocele. Men that are under the age of 18, still going through puberty and have size differences, usually more than about 20%. which is a little bit subjective because this is me literally doing an exam saying this one's a little bit bigger than that one. I would say that's pretty uncommon. Most people see pediatric urologists. I do every once in a while see somebody coming in for that. You mentioned pain. That's an excellent one, but there are some nuances to that. Somebody's telling me they're having pain. I usually ask pretty detailed questions about when the pain comes, how long it lasts, what makes it go away. And if you're not giving me the right answers, I'm probably going to tell you the pain is very unlikely to be due to a varicocele and correction's not indicated.
After I work out, after I take like pump or nitric products, driving home in the car is when it happens, especially when I'm on HCG as well.
Yeah.
There's your answers, folks.
Yeah, the answers are.
That's what it is.
It's true, though. It's long periods of standing or sitting because it leads to venous pooling, right? These are veins draining the testicle that are dysfunctional, that typically do not allow the blood to return back to the heart. So anything you do that increases pressure, gravity being a big one, vasodilation being another big one, are going to cause the swelling of this, and then that in turn is going to cause that discomfort. So if you're telling me you get out of bed every morning in pain, I'm going to tell you it's probably not the varicocele. If you tell me you lie down and the varicocele, the pain goes away within a few minutes or an hour, that's pretty compelling. The last thing, and probably the most common reason I repair varicoceles, is for fertility abnormalities. Usually if you see me, you'll get a semen analysis. And if there's any abnormality and you want to have future fertility, we would consider correcting the varicocele purely to maintain someone's fertility.
Do you think that the testosterone increase of 100, does that wane over time, or do varicoceles come back more if you ligate them versus embolize them?
Yeah, I don't know. We don't have follow-up data on that study to know whether or not that continues to go down afterwards. We didn't have a second measurement to know if that was even a very valid representation of a testosterone increase. In terms of recurrence rates, that's a great question. This is another area I've published in, looking at the cost efficacy of embolization, or when the radiologist take a small coil and put it through a large vein and block the veins off internally, versus surgery, which is something I do. I do what's called a microsurgical subinguinal varicocele ligation, or varicocelectomy, which is the tying off of destruction of the veins before they even get near the testicle itself. Recurrence rates have historically been higher, somewhere between 2 and 4% with the interventional radiology procedure, and less than 1% with the surgical procedure. It's a little bit difficult to tell that if more contemporary techniques in interventional radiology have changed whether or not that embolization has approached microsurgery. And I will admit I'm a surgeon. I like to operate. But when I talk to patients about this, I say the recurrence rate is probably pretty similar between the two. The big differences I find is the what could go wrong, the major complications. And one is the radiologists are putting a needle into a very large vein in your leg. You can have a major bleeding complication, which I tell people is incredibly rare. They do this every day. And then for my procedure, there's a small chance of injuring the testicle. Again, that's less than a fraction of a percent, but it's a real risk. And the other thing is recovery. The interventional radiology procedure, most people are back to activity by a week afterwards. Most of the time, mine is 10 to 14 days. But again, if that 4 days is the difference between you going back to work and making money and not, I totally understand that. But these are important conversations to have with your physician before pursuing some kind of correction.
Yeah. I was going to ask about venous leak, but I don't know if we have other things to discuss regarding varicocele. But it reminded me that a lot of patients with erectile dysfunction or sexual health concerns, a lot of them want to see a urologist to rule this out. And then some of them don't. Some of them just want to trial meds. What would you tell people that have this question?
Yeah, I mean, veins have a lot of problems in sexual health, as you just alluded to. Venous leak is tough. Venous leak is really tough. Looking at epidemiological studies of this, there aren't ones that, say, hey, it's 10, 15, 20% of all erectile dysfunction. Again, most of these are self-reported. There's a huge selection bias of who actually ends up getting this diagnosed or not. The gold standard for diagnosis of this is duplex ultrasound, which I actually do myself in the office. And, what we find is that the criterion people use to define this is a little bit different. A lot of people will look at how much blood flow goes in, and then when the heart stops beating and starts filling back up, we look at how much blood is left in the venous system. And if that is too high, we declare it a venous leak. But there's some nuances that go into this. The first is that if somebody is getting inadequate blood flow in, I don't really care what their blood flow out is. So you can't diagnose somebody with a venous leak who has arterial insufficiency, which is basically too little blood flow in. You have too much blood flow out, but you're not getting enough in to begin with. I think this, to digress 1 second, talking just about penile physiology here, you can imagine that when you get increased blood flow in, the goal is to have so much in that it actually closes the veins off. That's where this leak comes into place, that it's inadequate closing the veins off. But if you're not getting enough in to begin with, you're not going to have inadequate venous closure. So some people are mislabeled with this venous leak that truly have mixed venous disorder, mixed flow disorder, where they have both arterial insufficiency and venous leak. You brought up another really good point here, which is that some people want to try medications. Our guidelines, again, somewhat antiquated in this space now. There's actually a call for new guidelines for the AUA. I put my name in. I don't know if I'll get it.
We will vote for you.
I think it's really important here that the guidelines really went from back in the 2000s through 2010 era of you try pills, you try a pump, you try an injection, you get a surgery. And if you stop it anywhere along the line, that's fine. The new guidelines really talk about, hey, here are all the options. Pick what you want. You can choose any of these options. They talk a lot less about diagnosis of specific types of erectile dysfunction. And there's a reason for that. And the reason is we don't have good treatments for venous leak. We don't have good treatments for arterial insufficiency. We've tried all kinds of things, ligating veins, blocking veins, cutting parts of the penis off to try to allow for more blood flow in other areas. And for the arterial insufficiency, similarly, you'd think, well, if my heart is blocked and I get a stent, maybe that would help. Stenting pudendal arteries, which lead to the penis, grafting on new arteries, kind of like a coronary artery bypass graft.
Wow.
No good data in this space. Well, let me rephrase. There's one thing that's recommended by the guidelines, and it is somebody has a unilateral or one-sided injury or one-sided area that's affected. They're a non-smoker. They're not diabetic. They have no other comorbidities. Then you could consider some revascularization procedure. So I would like to call that a unicorn because I very rarely see that. But the reason we try these options is because we don't have targeted therapies for the most part.
A couple questions regarding that. One, you mentioned guidelines, so it made me think of the overwhelming number of comments I know we will get saying, you guys should have discussed finasteride and dutasteride and 5-alpha reductase inhibition in this podcast. It's probably best saved for a future podcast just because the rabbit trail there is huge. But when these guidelines are updated, are you speaking more just about erectile dysfunction in general? Because I know we want to ask you about different causes, since only 40% is psychogenic is what it says if, that's kind of a common quotation. But if it's ED in the guidelines, is TRT going to be one of the options optimizing from a low normal level?
So the current guidelines on erectile dysfunction say that we should be checking testosterone in men that present and appropriately treating them, and then reference testosterone guidelines.
What if it's 400?
Yeah, I think that's a really good question. That is certainly something that is going to come up in the new guidelines. The goal is that the things that have come out since the last guideline release are going to be beyond the scope of this podcast, but shock waves, platelet-rich plasma injections, stem cell injections, where they are, I think will be a major focus. I think testosterone will certainly come up because of all this direct-to-consumer marketing of testosterone when it's appropriate. Again, some of this historic data, you were talking about 40% psychogenic. People have quoted 10% is primarily endocrine dysfunction, meaning somebody with testosterone deficiency. I can tell you the people that I have that respond to testosterone the best are people that are either have no testicles because we cut them off for cancer, or people who have been given androgen deprivation therapy or hormone withdrawal therapy that never recovered afterwards after having prostate cancer. Those patients I know have a much higher chance of getting their erections back when we augment their testosterone. Beyond that, we don't have good questions. We do need data in that space. Again, without doing a complete literature review, I'm going to make an assumption or a hypothesis here that I think it will be a future directions item, even though these guidelines probably will not be published till 26 or 27. I bet that is in the future directions, testosterone monotherapy for certain subpopulations with erectile dysfunction.
And when it comes to lifestyle, there's lots of things people can do to improve their erectile function without going to, pumps or pills. Not necessarily that those are bad things, but how do you counsel, let's say, your type 2 diabetic, overweight patient with untreated sleep apnea that comes in talking about ED? What are going to be the biggest levers to pull for a patient like that?
I'm going to send them right to you. No, you bring up an excellent point. The data is a little bit more murky on this. Obviously, treating undiagnosed comorbidities is important. Getting better glucose control, taking care of someone's sleep apnea, which again, obviously affects all their diurnal cycles, testosterone included in that, is important. But the thing we find, like the final common endpoint for a lot of this is weight loss. So I can sit there and give somebody a different diet. I can give them a different resistance or aerobic training exercise regimen. But there have been plenty of studies looking at this, and really the most important thing, and when it's controlled for, doesn't seem to actually change, is weight loss. So beyond controlling comorbidities, weight loss is what I talk about with a lot of my patients. I do think it's challenging, because you guys have probably seen men that come in and they're not overweight. They're doing what they're supposed to do, and maybe there's we can change it, add some more resistance activity or something. But I think we're in the margins at that point. So my advice would be treat untreated comorbidities and try to get into the normal weight for your body size.
For patients that perhaps have already lost a significant amount of weight, or maybe they haven't, and they just want suprapubic fat liposuction, I don't know if you've encountered this a lot, or maybe they're post-panniculectomy, which is tummy tuck, but they still have a lot of exogenous folds and whatnot. Are you seeing this trend as well? Because there's certainly a lot of people who are losing a lot of weight.
So we have a surgery that I don't do. One of my partners does, Dr. Brokehammer, called a unburying of the penis surgery, which is something that has become a major result of people losing a bunch of weight, but not having, they have this what's called lipodystrophy, or they have this abnormal deposits of fat that are left behind after these surgical procedures, or even after just, regular weight loss. They've lost 200-300 pounds, and the area above or surrounding their penis still has a lot of fatty tissue. In this procedure, actually, in this buried penis repair, we actually fix that either with liposuction or an escutinectomy, which is removal of that tissue, plus pinning the actual penis back down to the pubic bone. So I've seen a major increase in those cases, because again, you can do your best to lose weight, but sometimes the way your body responds is not in full. So
yep. Sounds like people should probably do that instead of going to a med spa style clinic and getting liposuction just on the suprapubic fat pad.
Yeah, I think that's great advice. And now maybe we shift a little bit. I think we've done a good job of not making you say too many hypotheticals, but now getting into epigenetics, which we were chatting a bit about before we started recording. What are your thoughts on epigenetics and fertility? A lot of people, myself included, would tend to think like, hey, when you are starting to conceive, let's try and do things as naturally as possible. Paper probably 1 or 2 years ago now with metformin taken by the fathers seemed to be correlated with, again, very low, but a little bit of a signal towards, hey, this might cause some issues with sexual development in the male fetuses. So I guess kind of give me your take on epigenetics. Do you think about this in your practice, or is it something where you're seeing cases where you're pulling so many levers it's sort of on the back burner? Or just what are your thoughts in general on, is this something people should consider or not?
Yeah, that is a tough question. Realistically speaking, usually by the time someone's gotten to me, being able to have a child is the end game here. I think that it is important to really think about the progeny's health beyond just being able to have one, but there's so much emphasis and effort being put into finding the right sperm and doing the right thing that epigenetics, unfortunately, I wouldn't say just my practice, I think in general, have taken a little bit of a backseat in that regard. But I don't think that makes them any less important. I was listening to a talk at the Society of Male Reproductive Urologists a few years ago. Somebody got up there, started speaking about epigenetics, and I'm going to be some hotshot and raise my hand and be like, but we don't even know the genetics of male factor infertility. And obviously, this person is very intelligent. They're an NIH-funded researcher in this area. And I wait and I listen to the rest of the talk, and they go, and the reason epigenetics are more important than genetics in this standpoint is that we can do something about this. Right. These are things that we can intervene on potentially. We can change these DNA signals or these methylation patterns through lifestyle modifications, whether that's being on metformin, or again, we won't get into the finasteride, methylation signals, or stopping smoking or stopping drinking or becoming more active. I think epigenetics are incredibly important in this space. But right now, we're using them more as a marker, and we don't have the interventions we need to be able to actually correct some of these things. So again, living a healthier lifestyle is the one thing we do know. does significantly impact some of these methylation patterns.
Are you also asked about SSRIs frequently?
Yeah, I get asked about somebody will come in with a drug list being, what should I be on? And that's really tough because some people that come in on SSRIs can't come off of them, right?
Mhm.
If it's something that they haven't been off of in a decade and it's unclear reasons for why they were started, maybe they had anxiety around exams, it may be reasonable to see whether or not they can come off of this. But this goes into the whole conversation of balancing the theoretical risk of, I think that study was actually looking at testicular development in rats, if I'm not mistaken, with SSRIs, and different methylation signals and testosterone production in the offspring and men who have boys. But, it's difficult because you need to balance the patient and their progeny. If they can't come off these SSRIs, and this is the only way they're going to function, then that's a problem. I run into this more actually with, ejaculatory issues and people being unable to reach climax because they're on such high doses of SSRIs. And then, usually I'll call the prescribing physician and the three of us at the same time will have a conversation about, hey, can we brainstorm a way to either change these medications, or is this, this is a side effect that really stinks, but the alternative of you having these mood-related issues afterwards is way worse than the side effect.
Mm-hmm. Yeah, sometimes more complicated than just switching from Prozac to Trintellix.
Right.
Yeah. And now I do have a follow-up. We'll circle back to Clomid for just a moment. Is there any, or again, hypothesize as you feel appropriate, any beneficial mechanism of action aside from increasing the LH and FSH? So things I'm thinking of there is maybe the slight increase in SHBG, or perhaps even binding some estrogen receptors and antagonizing or agonizing them in testicular tissue.
Clomid's a dirty drug. I think this is going to be very tough to unpack. There was a trial for N versus Zuclomifen a long time ago that didn't end up getting funding. And I'm talking about the two isomers that are in Clomid. N-clomiphene tends to be a more testosterone predominant, Zuclomifen an estrogen predominant form of the medication, with Clomid being more of the estrogenic effects compared to the testosterone effects. This is a very long-winded way of me telling you, I don't really know. I do think that there is some benefit to have that increased SHBG, but the other thing we know is that the testosterone to estrogen ratio, and again, this is based on clinical data, shows that men with a testosterone to estrogen ratio of less than 10-1 tend to have an increased risk of infertility, decreased success with assisted reproductive technologies. So while there may be some benefits to SHBG, I think the negatives of having this potential hyperestrogenemia could outweigh that. So again, very important to not only follow the FSH, LH, but I also follow the testosterone, the estrogen, and the ratio between the two of them.
And I don't know the answer to this question. I don't know if there is one, but do you know if Clomid is specifically an antagonist or antagonist in testicular tissue?
I don't know.
I know it's not mapped out very well in the body.
I don't know. I mean, really, again, it typically affects the estrogen receptors, and I admittedly can't tell you what that looks like, on the Sertoli cells, which is probably where we need to look at them.
Could also be different on Sertoli cells and Leydig cells. I know that some SERMs, like raloxifene, even in the prostate, they can be an agonist and an antagonist at, say, the alpha receptors, but antagonist at the different at the beta receptor and different at the other estrogen-related receptors. And I don't think we even know if most SERMs bind to the membrane estrogen receptor. So it is certainly complicated. The androgen receptor is nice because, as far as we know, there's only one of them, but there's so many different estrogen receptors. Quick question on that. Is there an estradiol level that is so low or so high to where males should consider measuring a sensitive estradiol level if they want to be very accurate with it?
Yeah, I mean, one of the problems with this is that we're usually looking for downstream consequences of these perturbations in estrogen. Low levels, we're looking for things like fractures. People can actually have sexual dysfunction when their estrogen is too low. Anytime I get something back that's less than 15 or less than 12, depending on what lab I send it to, if the person's asymptomatic, I usually don't go off and send out further test. Likewise, if it's, above 35 or 40, they don't have any development of breast tissue, they don't have any symptoms or having fertility problems, I usually don't go ahead and check it. There's definitely some theoretical concern of venothrombotic events. There's that recent randomized controlled trial in the New England Journal last year looking at just the safety of testosterone in general from a cardiovascular standpoint.
Yep.
And, you guys have probably delved into the data before of this. None of the adverse effects other than the predetermined cardiovascular ones were pre-powered, but there was a slight increase in thromboembolic events when you looked at pulmonary embolus. And again, some of the questions surrounding that are why, and some people think it may be due to this increase in estrogen. So maybe it is something that we do need to be more mindful of. We have reasonable data in the female population with, estrogen replacement, systemic estrogen replacement, and maybe this is something that we're not doing a good job of diagnosing in men. But I don't have thresholds because I don't do it.
On the topic of lab tests, we were talking about 17-hydroxyprogesterone. We recently did maybe a 4-month trial run where we switched, and instead of eating the direct free testosterone assay, we started getting equilibrium dialysis. And at least with LabCorp, to me, it looks like it tends to overestimate free T. I don't know if you've had a lot of head-to-head comparisons of those, because if I recall correctly, the literature was suggesting that equilibrium dialysis is more specific, more sensitive.
It is what WADA wants you to test.
Yeah. So my follow-up question to you would be, when you say overestimating, what was your gold standard again there?
Yeah, so if I'm doing, let's say, a calculated free T, the direct free T I've seen inconsistencies with, but it's probably generally within 25% plus or minus of what I calculate with, because I have the SHBG and the albumin to do that. But if I'm doing a calculated, it's rule of thumb, maybe 2% of the testosterone is free. Equilibrium dialysis, I'm seeing closer to 3 or sometimes even 4%.
So my presumption is actually that the equilibrium dialysis is probably right and that our calculations are probably wrong. At least that's, again, what the CDC would suggest when they try to make laboratory standardization of this. Same thing with the LCMS that we see with the different types of radioisotope assays that are used depending on what machine is used. There's actually a really good article in the Journal of Clinical Chemistry looking at all of these different machines and figuring out how off they are at different levels. I think one of the problems here is that, me making a blanket statement saying that is probably unlikely to be true. It probably depends on how high or low that measurement is. The equilibrium dialysis may be really good for very low levels and very high levels, whereas calculated may be fine in the middle. My turnaround to you would be, what does it matter? Does it matter when we're diagnosing somebody who has a, normal or low normal testosterone and we're calculating it? Does it matter if it's somebody that just wants to get the highest free T possible? And then my other correlate question would be, why not use bioavailable T if we're going to start looking at, the true form of testosterone that's likely connecting with the androgen receptor?
Sure. Yeah, I'm probably not going to manage those people particularly differently based off their calculated free T or their equilibrium, because we're sort of looking at the symptomatology. And if they're at 301, but the equilibrium dialysis says, hey, your free T is 14, but the calculated or direct is saying, hey, your free T is 7 or 8, then I'm going to say, well, how do you feel? If they feel great, maybe we go with that and say, yeah, we don't need to worry about this. But it is interesting because then you would presume maybe some adjustment would be made to the free T reference range, depending on which assay becomes I don't know if Guidelines would address this, but which one becomes the more popular assay?
So the Guidelines right now say equilibrium dialysis. I think the bigger problem, and I think, Kyle, what you're going to talk about is just the difference between every individual set point in testosterone, right? Maybe the assay is right. Maybe it's just that some people have different levels that they feel differently at. And again, we're not going to the super physiologic here. But I was just at the South Central meeting at the AUA, and I was on a panel with Mohit Kira. Dr. Kira is one of the people on a lot of the guidelines. And somebody asked him the same question. They're, well, I have a patient that comes in, their level's 400. Their free T is normal on equilibrium dialysis, but they don't feel right. Like, how do you know what their level was before? Right? So if you put somebody like that on testosterone, get them to 600-700, and they feel better, the question becomes, where do you draw the line? And that's something I'm hoping the testosterone guidelines, when they are revised, have some clarity on. Because that type of logic doesn't really draw a line. It just says more is better, and we keep going until they feel a difference. But when do you stop? And I don't know if your guys' practice, I usually stop if that trough level is above 750, 800, which is typically what I'm measuring for either Q weekly or twice or 3 times weekly dosing. But I don't have a good answer to that.
We have a couple of markers, I would say, we correlate clinically. Like even if someone is at, say, a fairly steady state of 600, but their SHBG takes a big drop, the HDL takes a big drop, their blood pressure goes up, their LDL goes up. It's kind of, to me, a sign of, hey, looks like we're getting a bit of extra androgenic input. I know that's not going to be in any guidelines, but sort of just knowing how testosterone and androgen act in body systems, it's something we can kind of use to gauge, like, hey, if we're causing a problem, it's probably not the right route, or it's probably too much for somebody.
We've gotten flack for this, but some patients on testosterone replacement with a level of 700, it's too high. Maybe their DHT is 60 and their free DHT is 12 and their SHBG is 12. So if we're going to nitpick the difference between a free testosterone of 10 and 15, does that really make a bigger difference than the same two patients, except one of them, their DHT is 3 times as high? And if we have a patient that's on, say, a low dose of dutasteride or even finasteride, then are we going to stop at 750 for that patient? Perhaps not, because their total androgen load, which we call androgen pool, might be relatively much lower compared to another patient who comes in who's complaining about their total testosterone only being 500, yet they're applying their topical cream scrotally and their DHT is 300.
Yeah, I mean, I think you both have brought up excellent points here. And these are things that do not make it into the guidelines that probably should. We do have other objective measures of the downstream effects of anabolic replacement or giving somebody testosterone replacement.
PSA changes for androgenicity.
Yeah, and I will tell you that made it to the guidelines, obviously, because these guidelines are written by
Hematocrit makes it in there.
Sure, You're right. Again, things that are easy and understandable by urologists. But again, as I said to begin with, I do not routinely get lipid panels on patients. I'm not getting necessarily DHT levels in patients. And that's why we need more people that are actually going to incorporate these measures so that we know how to manage these patients. Otherwise, what we come back to, well, how do you feel? But again, that line you're suggesting to me should be drawn by other objective measures that we have. We have access to these things. Maybe these are things that we should be testing in future trials. The problem is we fall back on dogmatic literature, PSAs, hematocrits, cardiovascular events, MACE reporting, these things. And that's probably woefully inadequate to actually determine the upper limit of what we're supposed to do. But again, we're focused on treating low to normal. And we let the other side of that scale kind of go unchecked. And I think it's a design flaw and something we do need to be better about when we start to publish future literature.
Yeah. And on the subject of levels, with the Traverse study that you had referenced and seemed good for cardiovascular safety, cardiovascular events, MACE. But if you look at the levels, if people are starting with maybe a 200 to 250 baseline and they may be increased to 100, 150 nanogram per deciliter, some people would say that doesn't give the testosterone a fair chance to cause events because maybe people are being replaced higher than that in practice. But do you think that it still provides a reassuring safety signal overall?
Yeah, I think there are problems with a study designed like that in terms of generalizability. I do think that it provides a good degree of reassurance. And that's because the study population, as you guys know, are people that either had a previous heart attack or people that were very high risk of having one in the future. So we're taking the most at-risk population, presumably with saturated androgen receptors at that level, which was part of the inclusion criteria. And we could talk about the prostate effects of this as well. And putting them slightly higher than they were, just seeing if there's anything else that's going to cause it. And again, we could talk about peak levels. Is this applicable to injections, especially people getting on things like Aved or Testapel or just on twice weekly injections of 200 or 300? The answer is we don't know. But I do think there is some degree of reassurance for at least low levels of replacement that it doesn't increase or majorly increase these risks in a controlled setting. But to me, that emphasizes that controlled setting, which is something that I think is very close to all of our hearts, is making sure these men are well looked after, that they have repeat follow-up labs. You mentioned that flow diagram earlier, that somebody's following all these other surrogate variables. I mean, there's been a number of publications since the Traverse trial looking at just hematocrit levels and potential thromboembolic events. We talked about estrogen. Maybe this is something we need to be looking more into in terms of thromboembolic events. But I think more of this will be on the monitoring side than it is the initiation in an appropriate fashion.
I know in females, looking at ethinyl estradiol or synthetic estrogen and a likely bioidentical estradiol as well, the increased risk of thromboembolic events is directly correlated and probably caused by the increase in platelet count. So you think of estrogen binding to the estradiol alpha receptor in the liver as increasing that, but it's certainly not the only mechanism at which androgens can increase VTE risk, because thromboxane A2 also makes platelets stickier. For a patient that comes in and is really worried about that, maybe has a family history, I know that if you look at the hematology guidelines, generally it's recommended against to routinely check for things like prothrombin, which is factor 2, or factor 5 laden heterozygote status. How do you approach a situation like that?
Yeah, I think it's really challenging. And at the end of the day, we don't have clinical data suggesting that they are at increased risk for thromboembolic events being on testosterone. It's a hypothesized risk from two different things. You have a hypothetical risk from being a carrier of factor 5 Leiden, and you have the quote hypothesized risk from being on testosterone. And we're kind of enacting this two-hit hypothesis that if we do two things, they're going to get a thromboembolic event. I can't tell you that we know that's true, though. So I tell the patients, I think I said this earlier, I say, I don't know. We don't have data here. You have a theoretical higher risk for having a blood clot based on this, and there may be a small increased risk based on this. How the interplay of these two things work, I can't tell you. I can't. I was like, there may be a risk here. Is this something, how bad do you feel? Like, is this something that makes sense to you? Or you're saying, hey, I know this may be a theoretical risk. This isn't worth it to me. I don't feel that bad. So I really think this is a very much a patient-centered decision model than it is I can tell you that you're at higher risk and we shouldn't do this. I try very hard not to be, prescriptive or paternalistic with my patients when I have the ability to do so.
Do a lot of patients ask you about aspirin or even nattokinase that are at risk, or even things like ARBs if they have persistently high hemoglobin hematocrit?
Yeah, most people ask about aspirin. And again, I think that data has been somewhat in flux, and just having people on regular aspirin, whether or not the baby dose is enough to actually have any meaningful activity, I'd say that really gets outside of my area of specialty, and that leads to hematology referral, and usually don't give them testosterone.
Yeah,
might in
I
basket.
could see that
Yeah.
happening. Yeah. You mentioned future areas of research and study, and one of the areas of research that you've looked at is the question, should you give FSH to men that want to be fertile? And it's a common question. A lot of people ask us, do we need FSH? In our clinic, it's very readily available at actually a pretty cheap cost for patients that are here. But also, we don't want to give it to everyone. And I don't know if you want to speculate on what the future research on that might show.
Yeah, I have an immense amount of disappointment here. And that's that KU is a trial site for the ADAM trial, which was looking at FSH for idiopathic male infertility with an attempt to actually show a benefit in a randomized control fashion. We were a trial site for 2 years, and the trial is now shut down. The trial shut down due to lack of recruitment. Unfortunately, the inclusion criteria were very strict in terms of what the semen analysis could be, how old the partner could be, the BMI of the patients, and unfortunately, it was not a pragmatic trial design that would allow for completion. There are several retrospective, I can think of 2 done in this space, which is what the guidelines, the American Urological Guidelines and the American Society of Reproductive Joint Guidelines that recommend FSH for people with idiopathic male infertility. Really, I think more of us would use this medication if it was cheap enough. And you'd allude to the cost, and that's a big thing. I mean, through the standard channels that I get it for, we're talking $4,000 or $5,000 a year. Which, if I'm telling people I don't have great evidence, IVF is where you're potentially headed, and that's going to cost you $10,000 to $15,000. How can I justify somebody being put on, a medication that's going to cost another $4,000 or $5,000? The area I publish in is talking about whether or not we should be using this for people who are azospermic. Is there something that we're missing? Either at the FSH receptor, the total amount of FSH. I hate to say it, but I think our knowledge of how this works is pretty poor. I just read a review article earlier this year looking at the FSH levels in males as they go from birth through mini puberty to adulthood. And, it's clear that there's a profound impact on the Sertoli cells in terms of their architecture, protecting the stem cells of the spermatogonia. But beyond that, I'm not sure. I mean, I think some of our best evidence comes from men who don't have any. So if people with like Coleman syndrome, where they don't actually have any production of LH or FSH, and you give them back some of the, LH lookalikes like HCG, but they're not fertile until you give them some FSH. But then we see that all of a sudden we withdraw the FSH and they're still producing sperm. So clearly there's some paracrine factors or something that we're missing in this equation. We could talk about cross-receptor reactivity due to, similar alpha and beta units, et cetera. But I think clinically we're missing something here. I applaud you for having the availability of the medication. I think it's underused. I just wish that we could have had better randomized data to show how potentially, useful it is.
I bet we could make that happen.
We'd love to see a study like that. But
yeah, we'll ask Derek. We'll ask more plates, more dates, Derek, because he has pretty big reach, and I'm sure that he has a lot of viewership that
maybe you're struggling with that.
Idiopathic infertility.
Yeah.
Yep. So we might be able to reboot that. Speaking of Kallman syndrome, what do you think of this trend, which honestly, I think that Gonadorelin was mostly popularized. Not that I think it's completely not useful, but when HCG went to basically a Pregnil or Avidril or whatnot, there's this big trend to prescribe both injectable and troches and other forms of Gonadorelin, which you classically think of in Kallman syndrome. But what are your thoughts regarding that?
The administration of it's a little more difficult than HCG. I'm not sure what the pricing of it is, and the clinical data outside of people with very specific mutations is very lacking. HCG, as we, with the exception of several people who are hypo or specific things, are not FDA approved. There's not clinical data, but we have a lot of off-label clinical data in men taking HCG. I can't tell you I've seen a lot of data on people taking, GnRH agonists or, used in this setting. I've had several patients come to me on it, and I tell them I don't primarily manage this, and if they want to see an endocrinologist, who again, I can admittedly tell you, I get a message back. Yeah, I get a message back saying, I've never seen this before, because again, Kallman's is usually diagnosed by pediatric endocrinologists and treated then. I mean, we talk about these workups, but a lot of these are done before they get to the, adult life, with the exception of like Klinefelters, which I see somewhat frequently. But people with Kallman syndrome, it's rare. I don't know if you guys have you guys ever seen somebody with Kallman's?
We've had 1 to 2 patients in the 5 years we worked at Gillett Health and Merrick, I think.
That's impressive.
Which is thousands of patients that we've seen. I also have one other patient that managed more directly that was not diagnosed with Kallman syndrome, but did have what was thought to be idiopathic infertility, and always had very low LH and FSH levels, and had anosmia and a lot of the other symptoms. So I was like, well, maybe it's a touch. And then on MRI, they said possible indicative of Kallman syndrome. So that'd be a very rare adult kind of like subclinical case, I guess.
Just interesting they could have gone through puberty, or maybe they don't remember that they did get some shots or something during that time. I mean,
the patient history is another important element. And talking about the fertility, I wonder about this. So I know back in, I don't know how long it's been, but some of the studies trying to develop a male birth control. Yep. This is kind of an interesting space. Using Lupron in addition to testosterone seems to have a more potent effect on suppressing spermatogenesis. So I would presume even on like injectable TRT, you still have some low level of FSH and LH, but you're just not measuring it because it's, quote, undetectable by the lab standards.
Yeah, I would agree with that. I mean, right now, I'll tell you, there are several phase 3 clinical trials for both hormonal and non-hormonal male birth control, both in this country and in the UK. And right now, progesterone and testosterone preparations seem to be the winning out hormonal mechanisms. It will be interesting. They define success as less than 1 million moving sperm, which unlike female birth control, where it's either you're ovulating or not, I see people with 1 million sperm still get pregnant, right? I mean, again, the question is how efficacious is this? Probably will be something where it's 95, 96% efficacious, which is similar to OCPs for females. So maybe this makes sense. It's just, I get nervous when I don't see a 1 or a 0 signal here. And as you mentioned, same thing with the LH and FSH. Just because the lab can't detect it doesn't mean it's not being produced. You're absolutely right.
Yeah. And which do you see winning out? More of a hormonal or more of like a physical barrier, like a dissolvable hydrogel or something like that?
I see a hormonal winning out for several reasons. First, and again, this is my hypothesis. This is not based on any. Selfishly, I'd like to see the hormonal win out from a research standpoint, because one of my curiosities has always been taking somebody with a normal testosterone level and putting them on testosterone either to keep it normal or make it slightly higher. What are the long-term safety outcomes? And I think this trial, if this becomes a phase 4 trial and it's approved, I think we'll actually have reasonable safety data, 20-year follow-up on these patients. Like, wow, maybe these people are getting cardiac echoes at some point. They have premature heart failure. Maybe we're doing something wrong. Or maybe this dogmatic approach to not treating somebody with a T of 450 to make it 600 or 700 is actually not founded in any amount of evidence. The second thing is that when we start talking about the hydrogels and these other actual physical barriers that are injected, the question is, what is the downstream consequence of something like this? Well, downstream consequence, if your sperm production is really low, the chances of getting it back or going to the testicle for sperm are reasonable. The hydrogel thing, we're talking about a major surgical reconstruction that, isn't covered by insurance. And maybe it will be after this if it's I put in a modifier saying this is a vasal blockage due to an injectable something or something. But that's a 2.5 to 6+ hour microsurgical procedure, whereas the other one is a potential sperm extraction or something else. I think that's the potential danger of doing something like that. There are other non-hormonal, non-barrier ones where they start acting on some of the different cofactors necessary for sperm motility. So basically you're still ejaculating, but none of your sperm can actually be triggered for hyperactivation and then can't cause a pregnancy. Looking at cyclic GMP. But again, I'm not sure how close we are with some of those.
Yeah, thank you. I think we've addressed a lot of various questions, but I did have one other question that perhaps is our last question.
We really appreciate your honesty up to this point. When you say, hey, I don't know the answer to something, it's great to have someone with that kind of transparency. So
it's a sign of an expert in general if you say it depends or not that we know of at this time. But this one is purely speculative, and it's regarding how many people have tried TRT or anabolic steroids, because James and myself and some of our colleagues published a little article in Curious about the social trends in PED use and the searches for growth hormone and SARMs and tamoxifen, which is Novaldex, and Clomid. And the source that we found from 2008 said only 2.5% of American males have tried anabolic steroids, which TRT, testosterone, is certainly an anabolic steroid. And we'll post a link to that as well. But can you speculate on how many people have tried anabolic steroids versus testosterone replacement versus pro-hormones from GNC in the 90s versus, just one cycle, but it didn't count, or they tried it once from a med spa and they got a pellet, but then it extruded.
Again, zero data backing any of this up. I really would think it's probably a third. I really think a third of men have probably tried something that's maybe even higher than that. I think when things were...
It's just a little Clomid. Natural.
Well, it's not even that. I mean, it's just like, hey, my buddy found this thing online and he's made better gains in the gym than I have. Again, maybe I have some degree of bias because like the two of you, I like going to the gym. I hang out with like a different, if I'm looking at all men, maybe it's different. And the real question is going to be temporal trends in this. I don't know how many people are still necessarily going to the gym with all this, people working remotely and, what have you.
Yeah.
But I think it's a significant amount. I really would put it probably up there close to a third. I mean, I'll give you an anecdote. I went to, I'm from Chicago. I went to the opening Bears game, which was one they actually didn't lose. And I go there and someone's like, oh, this guy's a urologist. And I was tailgating with some of my friends. And like, yeah, I'm on T. And like 3 or 4 people came up to me, started talking to me like, yeah, I just tried to cycle. And these are men in their like young 20s. And I was like, you guys want to have children in the future? What's going on? Oh yeah, I'm not going to do this forever. But I was just so taken aback. I was like, again, this is not the population that I necessarily treat. This is just me meeting, some friends and friends of friends. And I'm like, this is, that's where I'm coming up with this number. Because it's like, as I started to talk to more and more people, we had like 40 or 50 people at this tailgate. It probably was about a third of the people that had either tried it or are trying it or plan on trying it or currently on it.
We agree. So, it's the same for GLP-1s, like Ozempic. So that's really what we see too. And perhaps I love that you acknowledged your observer bias as a urologist. whenever we're at, say, the gym, at wherever else, because we always go get workouts in, we'll inevitably talk about medications and peptides. And it seems like every single person that comes up asks about their regimen and what they should do.
Yeah, I really thought there that you were going to ask him if the telemedicine TRT created a red shift.
No.
Did that affect the outcome?
We should ask about that as well.
We can cut that if we need to, but
let's post that study up there too.
Did the telemedicine TRT epidemic affect the results of the election?
I'm trying to remember. I feel like the red wave for TRT is somewhat dated.
It is 10 years ago. We'll post the study up.
Yeah. So again, obviously confounding of whatever events were happening at that time. I don't have a good answer for that. I do think that it obviously could affect people's thought processes, right? We know that testosterone, DHT, and everything have receptors, androgen receptors in the brain. But I think beyond the actual physical response to that is you have to remember who's taking this, right? Like, are the people that are susceptible to voting either way taking testosterone? Like, what population are we studying here? And I think that to me is more interesting than whether or not testosterone affected them. What is this subgroup of patients? What is this 30% I just talked about of people willing to or going to be on testosterone therapy?
Well, an example, I would be shocked if Mark Zuckerberg is not on testosterone. He admits to being red-pilled and saying things that he would have changed. I'd be shocked if he wasn't. He's doing jujitsu. I'd be shocked if Elon Musk wasn't on testosterone. So as funny as the question is, I wouldn't be surprised.
No, I mean, and again, I think the question is the selection bias for the type of person more informative than the actual drug itself? And maybe it's a combination of both. But I certainly don't think we have evidence to the opposite, right? That there is no effect. This is definitely something that would be a really interesting study. I mean, you guys could do this prospectively in your clinic too.
Yeah.
You could give a 5-point Likert scale of which way do you politically lean, and then follow these men for a few years and see if that changes. And again, with all the confounding of who's up for election and all those other things, but it would still be very interesting to see if people's really do change over time, depending on their testosterone. I mean, you could just compare to their levels.
I love
to
that.
the DHT levels. Seriously.
Be a fairly simple study design to run.
Very good. Well, I think that is a fantastic place to end on. Before we wrap up and ask for comments and whatnot, is there a place online or social media where people can find you or get more information?
Go to the KU website. There's a few of them. There's one by the hospital, and then we have our own urology-ku.com. But you can learn more about myself as well as my department. We have some research labs, obviously very involved with trying to forward the urologic goal of providing care, both cancer and benign, to all men and women.
Perfect. Well, we will continue to beg to have you back in the future, and we will talk about finasteride and dutasteride as long as you're amenable to that. But as always, please type nice, mean, and in between comments below for the algorithm. And as always, thank you for your time, and may God bless you with health and happiness.